list, we have Toma. Sorry to interrupt. Do you wanna put it in a Facebook Live and then we can start?
Yes, sir. Just give me a minute.
Okay, then we'll start again. Sorry. Let me know when you are ready.
Dr. Mitro, and so please let me know when you want me to share the screen, please.
Yes, I will let you know.
Thank you.
Toma, are you ready? Toma, can we start?
Sir, just give me a minute. I'm just facing a technical. So
Sure. Yep. Technology is your best friend when it works. I think while we are waiting, I can see Dr. Humaira Tahsin joined as well. She's an associate professor in Popular Medical College. Professor Muhammad Ismail Patwari joined. So we have so many people here.
Sir, we are live now.
Okay. Good evening and good morning, everyone. Which part of the world you are joining from? We have an exciting topic today. Our topic is evidence-based best practice of anticoagulants, case-based discussion. We are really honored to have Dr. Farzana Haq as our speaker. I'm Chandan Mitra. I'm a lead faculty for the Planetary Health Academia for Internal Medicine. Our panelists are Professor Qazi Tariqul Islam. He is Professor of Medicine in Popular Medical College and also Editor-in-Chief, Bangladesh, a Journal of Medicine. We also have Professor Dr. Muhammad Mujibur Rahman. He's a Professor of Medicine at BSMMU. We also have Professor Dr. Dr. M.S. Sattar. He is head of the Department of Medicine, Chittagong Medical College. And Dr. Azizul Haq Azad. He's Associate Professor, Department of Medicine, Rajshahi Medical College. So I want to say a few words for Dr. Farzana Haq to introduce her to among our guests. Dr. Farzana Haq is an Assistant Professor of Internal Medicine at St. Louis University. She also serves as a co-director of acting internship and a medical director at SSM Health St. Louis University Hospital. Dr. Haq received the Caring Physician Award, Excellence in Professionalism Award from SSM Health St. Louis University Hospital. She was also awarded the Clinical Award, Physician of the Year from SSM Health as the only physician from St. Louis area. She was featured twice as Movers and Shakers by the Hospitalist News magazine. Dr. Haq is the president of the Society of Hospital Medicine St. Louis chapter. She has been invited as the speaker at multiple regional, national, and international conferences. The American College of Physicians has selected Dr. Hawk to receive the Young Achiever Award for 3 consecutive years. So without further delay, I want to take Dr. Farzana Hawk to start her session. Dr. Farzana.
Thank you so much, Dr. Mitro. And thank you, PHA, for arranging this session, and to our distinguished panelists for joining us today. I also want to thank you to all of you for joining us and for your interest on this critically important topic. I'll make sure that I'm sharing screen first. Are you able to see my screen, please?
We can
Yes,
see the
fine.
slides.
Yes.
Person.
We can.
Awesome, thank you. So first of all, I do not have any relevant financial disclosures, and I will not discuss any off-label investigational device or medication. Today, my goal is to have better understanding of the global impact of anticoagulants. We will also focus on evidence-based best practice of anticoagulations. And doing so, we will analyze multiple cutting-edge research articles and guidelines. So let's see what will be the outline of this session. We will discuss 7 clinical cases, which will be closely resemble to your daily practice. And during going through these 7 clinical cases, we will learn multiple key points from each case, which we can apply during a clinical practice. I will also make sure to have enough time to interact with our distinguished panelists and with all of you so that we can learn from each other's experience and expertise. I believe before we move ahead with our 7 clinical cases, the biggest question is, why anticoagulants? Why all of us are joining today to learn on our skill about this medication group? If you take a look at this number, and it shows that really how many patients are on these anticoagulants, both on warfarin and direct-acting oral anticoagulants, Epix-7. And if you take a look at these numbers, as you already know, that in this modern era, we are moving toward direct-acting oral anticoagulants like Epix-7, Rivaroxaban, warfarin than before. This chart shows us that within just a couple of years, a large number of our patients will be on anticoagulants. As this graph is predicting that by 2030, around $70 billion will be expended for anticoagulations. That shows us that what a large number of people we are predicting to be treated on anticoagulants. And here, if you take a look, that these 2 anticoagulations are used globally, and most of the reasons are 2. One is North America and then Asia. So regardless where you practice globally in any part of the world, there is a high chance that a large number of your patients will be on anticoagulants, or maybe at some point they will be the candidate of anticoagulants. So that's why it is critically important to learn and practice evidence-based best practice of anticoagulants. so that we can provide high quality and, most importantly, safe patient care. And as you know, that giving these warfarin and prescribing the ideal anticoagulations, it's not always very easy for the clinicians and not always very straightforward for our patients too. For example, many of our patients, they get overwhelmed by monitoring the INR. Be vigilant to be, having drug interaction, be cautious about what they eat. On the other hand, many of our patients are not financially capable to afford novel anticoagulations or direct acting oral anticoagulations. And a significant number of patients are not even safe candidate for direct acting coagulants. So that being said, now we will move toward to our first clinical case. And these clinical cases will be closely resemble that what you see in your day-to-day clinical practice. And when we go through these clinical cases, you will have opportunity to directly participate through poll system by choosing the answer. And I will encourage you to participate because that will give you the opportunity to brainstorm that how you will approach this patient when you are treating these patients in real life. Maybe you are not currently practicing, maybe you are a medical student or preparing for USMLE steps or any other licensing exam. I can tell you that whatever the clinical points we will learn from the 7 clinical cases, you will be able to implement those for your exams as well. So let's begin with our first clinical case. So this is a case of 65-year-old man evaluated for a single episode of painless gross hematuria occurred 1 month ago. Medical history is notable for atrial fibrillation, managed with metoprolol and rivaroxaban. Physical exam, vitals are unremarkable. Cardiac examination revealed irregular rhythm. Urine analysis normal. Ultrasound of the kidneys and bladder is normal. So to summarize, this question is same. This old gentleman came with single episode of gross hematuria. Patient is on rivaroxaban. Patient's vitals are unremarkable and UA unremarkable along with ultrasound of kidney and bladder. So now the question is, which of the following is the next most appropriate management? Now, 1, cystoscopy. Second, repeat UA in 1 week. Substitute warfarin for rivaroxaban, or reassurance and no additional intervention now. I will encourage you to participate in the poll and so that we can brainstorm how we will approach this patient in real life. So you can either use this web page, but just going to directly, or you can text, or if you are comfortable with the QR code, we have this QR code here as well. So we will wait few seconds and answer. Is there anything I can assist?
This is an excellent way to respond. I think you can go to that website, pollev.com, Farzana Haq 958, and you can answer that questions and it will show it up here, your answer anonymously. And we can see like where people stands. And once you log in, excellent. I think we do have one answer. The first time it takes a little time, and subsequent questions, I think it will be very easier.
Agree. Okay, so looks like the single boost option here is repeat user. So now we will see what is the right answer, and then we will find out the why that is the right answer. So the answer is cystoscopy. This question highlight some clinical points from the clinical guidelines that was published in internal medicine. Hematuria as a marker of occult urinary tract cancer. This guideline suggests some high-value care tips from the American College of Physicians. So let's see why this is cystoscopy. Hematuria is defined as presence of 3 or more erythrocytes per high power field. The key point from this question STEAM is that gross hematuria evaluation should be done even if patients are on anticoagulation or antiplatelet therapy. Sometimes we may think that, okay, patients are on anticoagulation or antiplatelet, maybe some gross hematuria are expected. The guideline is clearly stating that even one episode of gross hematuria, regardless patients are on any antiplatelet or anticoagulation therapy, must have workup because it could be the marker of occult urinary tract cancer. So even if we think that, okay, it's infection, even if you find that patient has urinary tract infection for any patient presenting with gross hematuria, guidelines recommend to repeat the urine analysis, sure that the hematuria has been resolved after treating the urinary tract infection. Ultrasonography is reasonable fast imaging, is available, low cost, as well as no radiation. After the UA and ultrasound are done, and if the ultrasound is unremarkable, then the next best step is to referral for urology for this. So now we will focus on our second clinical case. This patient, she is a 63-year-old woman evaluated in the emergency department for a 2-day history of melena with shortness of breath and lightheadedness from today. Past medical history is significant for atrial fibrillation. Only medication is warfarin. BP is 74/50, heart rate 136 per minute, and respiratory rate 20. Oxygen saturation 97%. Hemorrhage of the bright red blood per rectum is observed. Hemoglobin is 6.1 and INR is 8.6. Resuscitation is initiated with IV normal saline and blood transfusion. IV vitamin K is administered. So if we summarize this question STEAM, this is a 63-year-old woman present with acute anemia from significant blood loss, and patient is now having some hemodynamically instability. Patient's hemoglobin is low, less than 7, and INR is supratherapeutic. Resuscitation has already been started, and patient already got IV vitamin K. The question is, which of the following is the most appropriate additional treatment? Either ruxolitinib or protamine sulfate. So please choose your single best answer in this poll, and I will encourage you to approach this patient as you are treating in your practice, and then we will move toward the explanation part as well as the key points. Awesome. Okay, so majority of our participants chose option 2, 4-factor protein complex concentrate, and some of our participants also chose option 3, which is, so let's move toward, I believe we have some here as well. Thank you. So one is chosen PCC and another option is 4. Thank you for your participation. So now we will move toward the explanation part. So the right answer here is 4-factor prothrombin complex concentrate. So this, the American Society of Hematology 2000 guidelines management of venous thromboembolism. Supratherapeutic INR, patient is having significant bleeding, we deal with, in a regular basis in our clinical practice. So let's divide these patients who are having supratherapeutic INR into 2 categories. First group is having no bleeding, and second group is having significant bleeding. So now we will focus on the patients who are having supratherapeutic INR without bleeding. So if the INR is between 4.5 to 10, definitely we will hold warfarin until the INR normalize. What about if the INR is more than 10? We will withhold warfarin and administer oral vitamin K. Now move toward the patients who are having supratherapeutic INR and life-threatening acute bleeding. We will give IV vitamin K. So previously more than 10, we give oral, and now this patient vitamin K from 4-factor prothrombin complex concentrate. First, this is the preferred agent for warfarin reversal, and it contains 4 clotting factors, 2, 7, 9, and 10. And 4-factor prothrombin complex concentrate can also be used to reverse bleeding resulting from oral direct 10A inhibitor like apixaban, rivaroxaban, or entozaban. So now question is, maybe you have both. You have both 4-factor prothrombin complex concentrate, and you also have fresh frozen plasma. Which one to choose and why? If you have both, your go-to agent should be 4-factor PCC, because this is the preferred agent over FFP due to fast infusion time, more rapid reversal of INR, and low risk of volume overload. So for example, if you have a patient who is having acute heart failure and now having supratherapeutic INR, life-threatening bleeding, you should choose 4-factor PCC because of the lower risk of volume overload. One of the question stem was androstenedione alpha. Androstenedione alpha is the recombinant modified factor 10A protein. It is not indicated for warfarin reversal. It can be used for reversal of factor 10A inhibitors in case of any life-threatening bleeding, such as rivaroxaban or apixaban. Another option was idarucizumab. Idarucizumab is the humanized monoclonal antibody. And it can only be used for dabigatran's anticoagulation effect during life-threatening bleeding or who require an urgent invasive procedure. One here important to notice that for androstenedione alpha, it is not recommended to use for any urgent invasive procedure to reverse if the patient are on rivaroxaban or epizaban. So in that situation, we will use 4-factor PCC. However, for idarucizumab, we can use for life-threatening bleeding if the patients are on dabigatran or who require an urgent invasive procedure. So now we will move toward to our third clinical case. 73-year-old woman is seen for a preoperative medical evaluation before elective cholecystectomy. Past medical history is significant for non-valvular atrial fibrillation, hypertension, and diabetes. Medications are warfarin, metoprolol, and metformin. Which of the following is the most appropriate perioperative management of this patient's warfarin? So this patient will go through elective cholecystectomy. Patient has non-valvular AFib. Patient is on warfarin. So the question is what to do about this warfarin during this perioperative management. And I believe as an internal medicine specialist, we deal with this question very day-to-day basis. Our surgical colleagues reach out to us that what will be your recommendation during this perioperative period. So the options are withhold warfarin 2 days prior to surgery and restart 2 days after surgery. Second option, withhold warfarin 5 days prior to surgery, bridge with low molecular weight heparin. Our third option is withhold warfarin 5 days prior to surgery and restart 12 hours after surgery. And fourth is withhold warfarin 5 days prior to surgery, restart 5 days after surgery. So please take this opportunity to select your most appropriate perioperative management, and we will go from there. Thank you so much. I truly appreciate the participation. We will address those cases soon. Okay, so far, majority of participants chose withhold warfarin 5 days prior and bridge with low molecular weight heparin. Some of our participants also chose warfarin 5 days prior to surgery, restart 12 hours after surgery. So now we have almost like close between these two options. Okay, so majority of our participants chose the option to withhold warfarin 5 days prior and bridge with low molecular weight heparin. So let's move toward our correct answer and the evidence behind it. So the correct answer is 3, withhold warfarin 5 days prior to surgery and restart 12 hours after surgery. This question highlights the guideline that was published in CHEST, and this was the guideline about antithrombotic therapy for atrial fibrillation. Warfarin should be withheld a minimum 5 days before surgery to normalize the INR. And post-operative reinitiation of anticoagulation should be guided by the patient's thrombotic and bleeding risk and determined in collaboration with the surgical team. And I believe this is not always very straightforward. For example, for some patients who are having high bleeding risk, high risk procedure, we have to always collaborate with our surgical team. And for example, if some patient is having prosthetic mitral valve, the urgency of starting anticoagulation is much higher compared to the patient who is having non-valvular AFib. So it's always advised to think about both thrombotic and bleeding risk and talk to our surgical team. And warfarin should be restarted within 12 to 24 hours of surgery. pending adequate hemostasis. The timing of warfarin discontinuation is truly based on its half-life, 36 to 42 hours, and clinical studies that showed that how long does it take to normalize after discontinuation. And as we already know, that it takes 5 to 6 days to achieve a therapeutic INR for warfarin. I believe one of the key points of this question is that when to bridge with low molecular weight heparin and when not to bridge. Because as the attending physician, when I'm working with our residents, medical students, I get to ask this question all the time. And that's why I believe that this is very important to address and also remember it in our clinical practice. So let's see when we need to do bridging with low molecular weight heparin during the perioperative period. Highest risk for devastating thromboembolic risk. For example, a patient had recent PE, patient has high thrombotic risk mechanical heart valve like mitral aortic valve, or patient Chadwick's score is more than or equal to 7. So during those situations, we will bridge with low molecular weight heparin. If patients are not having these conditions, we do not need to bridge. So now we were moving toward our fourth clinical case. A 25-year-old woman is seen for pregnancy planning. She underwent mitral valve replacement with a mechanical prosthesis 4 years ago for congenital mitral valve stenosis. She is asymptomatic. She takes warfarin 4 milligrams per day and low dose aspirin. INR measurements have been within the therapeutic range for the past 18 months, including her most recent INR 3. Other than a mechanical sounding S1, vital signs and all physical exam are unremarkable. Echo shows a normally functioning mitral valve prosthesis and normal left ventricular function and estimated pulmonary artery pressure. She would like to attempt pregnancy as soon as possible. During this time, aspirin will be continued. So this is a young woman who has mitral prosthetic valve. She takes warfarin, and now she is coming for her pregnancy counseling. So the question is, which of the following is the most appropriate anticoagulation strategy during the first trimester? Option 1, stop warfarin and start bivaluridine. Secondly, stop warfarin and start dabigatran. Third option, stop warfarin and start subcutaneous dose-adjusted unfractionated heparin. Or fourth option, continue warfarin. So please this opportunity to see which one you will do while approaching this patient in your practice. And then we will move toward to the guideline as well as the key points. So far, the chosen option is option 3, stop warfarin and start subcutaneous dose-adjusted unfractionated heparin. Okay, so let's see what is the right answer and move toward. So the correct answer is here, continue warfarin. And I will go through the evidence and the rationale right now. So this can highlight the guideline from 2020 American College of Cardiology and American Heart Association guideline for the management of patients with valvular heart disease. This guideline was published in Circulation. The most important key point, I believe, in this question is that direct-acting oral anticoagulants are not recommended in patients with mechanical valve prosthesis. And warfarin poses increased fetal risk, including teratogenicity, miscarriage, and fetal loss because of intracranial hemorrhage. So the question is, if warfarin is teratogenic, why we are continuing warfarin in this first trimester? The answer is because warfarin teratogenicity or any risk to the fetus is dose dependent. So for pregnant patients who are having mechanical valve processes, during the first trimester, we can continue warfarin as long as the dose is 5 milligram per day or less. If you remember in this question STEAM, the patient's dose was 4 milligram per day. So as long as this is less than 5 milligram or less, we will continue for any pregnant patients with mechanical heart valve warfarin for first trimester. So what about second and third trimester? Second and third trimester, warfarin is the preferred anticoagulation for pregnant patients who are having mechanical mitral valve or any other mechanical valve. In patients who prefer not to take warfarin during the first trimester, or simply their dose is more than 5 milligram per day, for those patients, we will use IV dose adjusted unfractionated heparin. And another key point to remember here, that subcutaneous heparin does not provide adequate anticoagulation coverage for a patient with mechanical prosthetic valve. So we are almost more than half of our clinical cases. So if we quickly go back, so far we have learned that any patient who are on antiplatelet or anticoagulation and having gross hematuria, we need to work up for any occult malignancy of urinary tract. So far, we have reviewed 2018 American Society of Hematology Guideline. We have also reviewed the atrial fibrillation management guideline that was published in CHEST. And we just reviewed 2020 American College of Cardiology guideline about the how to treat patient with venous thromboembolism and mechanical heart valve. So now we will move toward our fifth clinical case. A 62-year-old woman is evaluated in the ER for 1 day history of left arm swelling and moderate pain. She was recently diagnosed with osteomyelitis on first metatarsal on the left foot. 6 weeks of IV antibiotic is planned. She takes no other medications. A left peripherally inserted central catheter, PICC line, was placed 2 weeks ago. So PICC line was placed because patient need prolonged antibiotic for osteomyelitis, and now patient is coming for 1 day history of left arm swelling and moderate pain in that same arm. Physical exam, vital signs are normal. She has left upper extremity edema. Pulses are normal in the left upper extremities, and no facial swelling is noted. The foot ulcer is clean. Granulation tissue is present. Duplex ultrasonography is performed on the left upper extremity and demonstrate an acute DVT in the brachial and axillary veins. The PICC line is functioning, well positioned, and not infected. The question is, which of the following is the most appropriate management? Start anticoagulation. Second, remove the PICC. Third, remove the PICC and start anticoagulation. Or fourth option, thrombolytic therapy. In our day-to-day practice, we see this like central venous catheter associated thrombosis quite a significant amount of time. So please take your time and choose what you think that you would do while approaching this patient, and then we will move toward to reviewing the guideline and to the key point. So our 100% participants so far has chosen option 3, that is remove the PICC and start anticoagulation. What else do you think you will do in this situation? Okay, so 33% of our participants are telling start anticoagulation, and then 40% are telling remove PICC and start anticoagulation. Okay, so let's see what is the right answer and the evidence behind this answer. So the answer is start anticoagulation, not remove the PEEP. So this question is highlighting the clinical practical guideline that how we will deal if the patient is having thrombosis with central venous catheter. The key point from this question stem is that central venous catheter associated with upper extremity thrombosis, that catheter can remain in place as long as it meet all three criteria. One, the catheter is functioning. Second, well positioned. And third, not infected. So as long as this catheter is functioning, well positioned, not infected, we can continue, we can keep the central venous catheter and start the anticoagulation. And we need to continue the anticoagulation as long as that central venous catheter is there. What about patient has completed the antibody? You have removed the central venous catheter. How long should you continue that anticoagulation? The guidelines support that we will continue anticoagulation in total for 3 months. There was one option that when to do thrombolytic therapy. We will do thrombolytic therapy because this is a easy procedure. We will do only when patients are having thoracic outlet syndrome, severe symptoms, if the patient is having severe swelling, redness, or any concern for acute limb ischemia. Now we were moving toward our 6th clinical case. This is a 22-year-old woman evaluated for pain in the right calf for 1 day. She reports no shortness of breath, cough, or chest pain. Medical history is unremarkable and takes no medication. So quite healthy woman coming with right calf pain for 1 day. Physical exam vitals are unremarkable. Tender venous cord is palpable in the right calf. No asymmetry in calf diameter is noted. Duplex ultrasound of the right leg shows an acute thrombosis of the right small spontaneous vein that is 7 centimeters in length. So this patient is having superficial vein thrombosis. The question is, which of the following is the most appropriate management? Anticoagulation for 3 months, anticoagulation for 6 weeks, vein ligation, observation with ultrasound guidance. So please choose your answer in the poll and we will go from there. So the answer here is anticoagulation for 6 weeks. This article highlighted the meaning of superficial vein thrombosis. So first of all, for superficial vein thrombosis, we can tell the patient to observe and follow up in 1 week to ensure symptom resolution. If the symptom persists or get worsened in 1 week, we need to repeat Doppler ultrasound. And if it shows any thrombus extension, then we will start anticoagulation. So what about this patient? We did not tell this patient to go and follow up in 1 week. We just start right away. We will start right away anticoagulation for superficial vein thrombosis, which is 6 weeks if the thrombus is 5 centimeters or greater in length, close to the deep venous system, or when other thromboembolic risk factor present. For example, patient has a surgery, patient is like prolonged immobilized, or patient has other thromboembolic risk factor. If you remember, this patient in the question is the length of the venous thrombus was 7 centimeters. So it is more than 5 centimeters. So the anticoagulation was started right away, rather than telling them to follow up in 1 week. An important point to remember that in contrast of deep venous thrombosis, superficial vein thrombosis, we will only treat for 6 weeks, regardless this is provoked or unprovoked. Because for DVT, it can differ. However, for superficial vein thrombosis, either provoked or unprovoked, we will treat only 6 weeks by anticoagulation. So this is our last case, our 7th clinical case. A 2-year-old woman has locally invasive ovarian cancer and will undergo abdominal hysterectomy and bilateral salpingo-oophorectomy. No personal or family history of venous thromboembolism. Vital signs are normal, BMI 37. Ascites is present. Rest of the physical exam is unremarkable. Intermittent pneumatic compression is initiated. So this patient who is having locally invasive ovarian cancer, now coming for total abdominal hysterectomy and bilateral salpingo-oophorectomy. No family, no personal history of venous thromboembolism. The question is, which of the following is the most appropriate additional perioperative venous thromboembolism prophylaxis for this patient? Insertion of inferior vena cava filter, low molecular weight heparin for 7 days, low molecular weight heparin for 4 weeks, or no additional thromboprophylaxis is needed. So this is our last question. So please choose your what do you think that will be the right answer, and then we will move to our explanation. Okay, so we have 50-50 between insertion of IVC filter and 33% of our participant has been chosen low molecular weight for 7 days. Majority of our participants have chosen insertion of IVC filter, and 25% have chosen low molecular weight heparin for 7 days. So let's see what is the right answer and the evidence behind this recommendation. The correct answer is low molecular weight heparin for 4 weeks. This guideline was published in Journal of Clinical Oncology. This was the guideline about venous thromboembolism prophylaxis and treatment in patients with cancer. So this recommendation, we are very familiar that any patient with malignant disease coming for major surgical intervention, we have to give thromboprophylaxis either with unfractionated heparin or low molecular weight heparin, unless there is any contraindication like high risk of bleeding or active bleeding. I believe this part is essentially crucial for our practice for cancer patients, because it's telling that if the patients with cancer coming for any major open or laparoscopic abdominal or pelvic surgery and who have any high risk features like restricted mobility, obesity, or history of VTE. If you remember, our patient's BMI was much higher. Patient was in the obese category. So according to this guideline, this patient, when this cancer patient is coming for any major abdominal or pelvic surgery and has this risk factor, restricted mobility, obesity, or history of VTE, we need to continue this low molecular weight heparin for up to 4 weeks post-operatively. So now we will wrap up, and I want to highlight the 6 clinical takeaways before we move toward our distinguished panelists. First, evaluation of gross hematuria should be done even if patients are on antiplatelet or anticoagulation therapy. Even single episode of hematuria warrant workup to be done. Secondly, thrombosis associated with a central venous catheter required 3 months of anticoagulation in total. warfarin is the preferred anticoagulation for pregnant patients with a mechanical valve master, as long as the dose is 5 milligrams per day or less. It is critical to know when to bridge with low molecular weight heparin, because if we are not bridging judicially, we are putting the patients at unnecessary risk of bleeding. So if the patient is having high risk, like recent PE, having high thrombogenic mechanical heart valve, like mitral valve, or if the CHAT-VAS score is more than or equal to 7, during that time, we will bridge with low molecular weight heparin. 4-factor PCC is preferred over FFP for patients with volume overload for warfarin reversal in acute bleeding. And one of the biggest points to highlight here, that direct-acting oral anticoagulants and subcutaneous heparin are not recommended for any patients with mechanical heart valve. There was a trial called Realign, and it showed that they tried to do dabigatran for mechanical heart valve. Truly, patient had more thrombosis and more bleeding. So mechanical heart valve, only our option will be warfarin, no DOAC or subcutaneous heparin. Thank you so much for joining. I hope you found value in this talk, and I will be happy to answer your questions. Back to you, Dr. Mitro.
Thank you, Dr. Farzana Haq. This is such an excellent presentation, and you made some great points. I think anticoagulation is a topic that we all need to be familiar with, because nowadays the number, as you have shown, that increasing. Now, until few years ago, the options were very limited to Coumadin and low molecular weight heparin only. But then the direct oral anticoagulants, I think it made more complicated nowadays. But I think those the good thing, last few years, it has been widely available. The cost is reasonable, maybe getting reasonable as well. I think our panelist from Bangladesh can tell us better how available it is over there. And now DOACs are much more convenient sometimes, that we don't need to, but we need to choose our patient carefully. Which are the patients that will be on Coumadin, which are the patients that will be on DOACs, and what are the evidence behind it, especially when it comes to Coumadin low molecular weight. I think you covered some of those important topics. And before I go in, invite our panelists, I think I want to mention that Dr. Tariqul Islam will be very excited to know that Saidur Rahman is here from UK, and he made some comments. I know that he is one of your favorite students. I can see the smile in sir's face. So Dr. Farzana, you can go through some of the comment, and I mean, you can answer, or some of the I can answer as well. Now, one of the he made, especially during that non-valvular atrial fibrillation case, periop management. I think you made that point. And you know, depending on the country where we are practicing, some of the areas like in UK, in Bangladesh, there might be a little bit of difference. But I'm trying to remember the name of the trial. I think it's called Bridge trial, that bridging therapy during the atrial fibrillation in perioperative period, if I remember it correctly. So if the CHADS-VAS score is very high, and then if the mechanical mitral valve, I think those are the cases that you can bridge those patients. If not, then you can hold the anticoagulation. Like high-risk patient, we still need to bridge. But in low-risk patient, we can hold the anticoagulation for 5 days. And depending on the perioperative risk and bleeding risk, we can resume upon discussion with the surgeons in 2 days, 5 days, or 7 days, that when we can restart that anticoagulation. But I think I will invite our panelists, and to express their valuable opinion. I would like to invite our respected Professor Kazi Tariqul Islam first. Sir.
Thank you very much indeed, Farzana. It was a wonderful live session, case-based discussion. And the way you put the questions, that which one will be the right answer through some I think there are some apps, powered apps, so the answer could have been possible. This is the right way, where there are facilities and wonderful interaction could be possible. Sometimes I thought that I try to answer, but I was listening to you so very like a student. I was just like a student. I was listening to all of your steps and ups and down of your voice and your pause, everything. It was really excellent. I have nothing to add except some Bangladesh perspective, because other panelists will tell something. The last few 2-3 slides you have summarized that elderly person with gross hematuria one should not ignore, and it is very important that bladder carcinoma or prostatic carcinoma, whatever it is, maybe, because you mentioned I saw I have also noticed that you mentioned twice gross hematuria. So simple microscopic or just hematuria it was not. It is gross hematuria, means something is in the bladder, mitotic lesion is there. So this is very important. This was a masterly presentation, so it is just like a teaching. It is very nice, and obviously there should be consultation from the urologist. One or two important thing I will touch, because other panelists will talk also. I should not cover all the cases. In Bangladesh, 4-FPCC is not available. So what we do, if there is no contraindication like known heart failure or there is volume overload, we usually give FFP in those cases. And FFP is very common practice in ICU also. I can give you one example that in the last 3 months, 2-3 months, dengue had a very big outbreak, as well as the death was highest in the last 22 years. As because I do work with dengue, the national guideline is being made by myself with my team. So during dengue, when we saw in dengue there is problem, when we see that there is expanded dengue syndrome and the patients all parameters has come very bad condition, to avoid volume overload, what to do in those cases? Giving FFP is risky, but as we don't have, in those cases, though this is not a thromboembolic issue, but in those cases it is something different. So we use those one. Regarding the mechanical bulb, what you have told, this is very important. Definitely, we know through our interest, as well as go through the journal and online, we know this, that DOAC and subcutaneous heparin for many reasons is not effective. For many reasons, a older person, the elasticity of the skin lost. In dehydrated patient, it will not be absorbed. Like what you can remember, a patient with DKA has come and you are if somebody is giving subcutaneous insulin, it will not work. That is why it is being advised to push either IV or give in the intramuscular so that it can be absorbed quickly. I will stop by saying one words. In our setup, if I prescribe, being a clinician, a case is referred to me in pregnancy, I am using warfarin, I'm sure I will be humiliated, because many of our doctors, they know that whenever the patient is pregnant, warfarin is contraindicated for the baby because of the congenital anomalies and all others, and there may be intracerebral bleeding for the baby. So one thing I listen and learn from you, that still evidence-based medicine is telling that it is safe if it is less than 5, and your case it was only 4 milligram. So considering all these parameters that you have told to us and you have described very nicely, one thing is very important, that the last one, if I can remember, that a old lady with ovarian carcinoma gone transabdominal hysterectomy with BSO, then she developed ascites, means there is met in the peritoneal cavity. Here IVC is not available in Bangladesh, but IVC is a choice, I think, if it is not the number one. If I am wrong, you can correct me. But low molecular weight heparin for 4 weeks, when this is being referred to us, hematologist, Bangladesh, the number of hematologists is very few. So being internist, this is rather referred to us. So this part and this portion is very important, that low molecular weight heparin for 4 weeks is a good choice, because in the book there maybe it is written that sometimes you can block it by IVC filter, but in practice it is not possible in my setup. I am again amazed by your presentation. Thank you very much for a lot of very new aspects that you have really taken out, and this is, I'm sure that these are all real life cases that you have encountered in your practicing days. Thank you very much. I will stop, Chandan. Thanks once again to be part of PHA, and today I have learned a lot. Thanks again.
Thank you so much, sir.
Thank you, sir. Every time I listen to Farzana, I am amazed at especially with her presentation and the way she presents. And you focus on few of the key components as well, like hematuria. Regardless, sometimes we don't talk about the bias enough, that we have that anchoring bias and the other bias as well. So sometimes when people are anticoagulation, we have the tendency, because of our bias, to ignore those. But I think in case of hematuria, we never have to ignore, like in her case. And cancer and anticoagulation is a fascinating topic to me nowadays. And this is, in this patient, this is for the prophylaxis as well. But when it comes to treatment of the thrombosis, I think low molecular weight, and especially in the advancement of the DOACs, I think we all know, I believe the name of the trial is a clot trial, that low molecular weight heparin is superior to warfarin when it comes to anticoagulation in a patient who has malignancy. And then there are several different trials that came up since 2018, I believe. Like, I think the first one was Apixaban, that is non-inferior to Lovenox, then the Xarelto, then the Pradaxa. Those are, so now we can use the DOACs and have the more availability, and people doesn't have to use that low molecular weight heparin. But I think the way Dr. Farzana presented that in her cases, like for every single case, she presented an evidence that why she is doing and what she is doing. Now, pregnancy and anticoagulation is another fascinating topic. So yes, that article mentioned that it is a dose dependent, but at the same token that we need to keep in mind that because of a dietary habit, that INR sometimes can be wild, right? Some of the diet, especially spinach and the other things, can bump up that INR. So yes, that is also we need to keep in mind that yes, we are not focusing only the dose the patient is on is safe, but because of so many dietary interaction, we need to keep an eye on that INR as well. So now I want to invite Professor Mujibur Rahman. Sir.
Thank you, Chandan, for asking me to say something. Thank you, Dr. Farzana Haq, for your nice presentation, as you always do. This case-based discussion, I want to say one thing, that the practice of anticoagulation in Bangladesh is totally different. We use, in particular situation like AFib, non-valvular AFib, and atrial fibrillation with specific valvular disorders, we just straight away use non-valvular atrial fibrillation, the DOACs, the valvular atrial fibrillation, we use the warfarin. This is classical. The recommendations you have shown in your different cases, I'm not going into each case by case, but all are on the basis of recommendation on the basis of guidelines presented very recently. We in Bangladesh, we usually do not follow the guidelines, particularly the evidence-based guideline, because in one case you have told that the superficial venous thrombosis. We always told that the deep venous thrombosis, we have to go by these. But what should be the treatment in superficial venous thrombosis? This is very important. So these are the learning points for our trainees, for our students. Ekhane onekei trainee ache, those who are preparing for their different exams, they have to go through these guidelines, because in multiple choice questions, the single best answers, it seems that all the questions are true, but there is no false answers. All the questions are true, but which one is the most true? Which one is the most true, that has been selected by the students in the exam. And what really the guideline says, and that is the answer, because guideline will, there are several publications with these, several thousands of publications with this anticoagulation therapy. Very recently, in January 19, one article has been published in New England Journal of Medicine, that on prophylactic treatment of hip fracture, limb fracture, prophylactic treatment of deep venous thrombosis prevention. The aspirin and low molecular weight heparin, the aspirin is non-inferior to low molecular weight heparin. These have been proved by that trial. So whenever there is any question regarding these, you have to know that particular evidence. You have to know that particular publication. You have to know. So the things are being rapidly changing, rapidly evolving. So you have to keep eyes on the publications daily, and guideline and the recommendations daily to particular questions. In evidence-based medicine, there are PICO questions, and that questions how we can answer that particular question. On that particular, it needs to judge the population, it needs to judge the settings. After all these judgment, then you can give treatment to that particular patient. So this is what Dr. Farzana Haq has told before us, that how evidence-based medicine can be taken into account during the treatment of a particular problem of a patient. So I am not going into the every cases. So thank you again. Thank you, Dr. Farzana Haq, for your nice and well-articulated presentation. Thank you very much.
Thank you, sir. I think that is a great point that Dr. Farzana Haq mentioned, that superficial venous thrombosis. And I think Dr. Saidur Rahman also made that point as well, because of the nomenclature like superficial femoral vein, but that is considered as a deep vein. So we just need to keep in mind that yes. By reading that radiology report, it can be confusing, but because of the proximity of the deep vein, and that is a deep vein, though it is named as a superficial femoral vein. So now I would like to invite Professor M.S. Sattar.
Thank you. First of all, I would like to thank Planetary Health Academia for inviting me to be a panelist in this great discussion session. I have learned a nice presentation I have given by Dr. Farzana Haq, and the session has been enriched by wise discussion of Professor Kazi Tariqul Islam sir and Professor Mujibur Rahman sir. Actually, all the 7 cases has nicely been discussed, and all the cases are practice-based and evidence-based, guideline-based. So starting from the first case, which started with the gross hematuria case, that nicely mentioned by Professor, added by Professor Kazi Tariqul Islam sir also, that whenever a patient presents with gross hematuria, particularly in elderly, we must not forget, despite the taking initial steps of other measures like thinking of control of acute bleeding and stoppage of warfarin and others or everything, we should not forget to evaluate the case to rule out bladder carcinoma. As and any source of hematuria in disease, the first action was without be it minor, we know that in the hematuria case, first off, we should think of infection. Then next step is to think to rule out the malignancy by doing cystoscopy. It's a nice case discussed by, and the other things, all the cases is a clinically important. What we have learned in this session is that in valvular heart disease, as also mentioned by Professor Mujibur Rahman sir, is that in atrial fibrillation, atrial fibrillation not due to mitral valve disease. The other cases in use of the other into drug, but when it is related to the mechanical valve, prosthetic valve, it should be always be the drug of choice is warfarin. And the other cases has been mentioned by I think to me, it was a very nice session. I have heard Dr. Farzana's presentation before, and I also joined a different session at Sundar Mitra had in the previous session invited me to be a panelist. So I am much benefited out of this discussion. I'm sure my students who have joined here, as we invited them to join this session, much more benefited in this session. So I'm very thankful to the organizer to select me as a panelist here. And thank you again for this session, Dr. Farjana, and all the panelists and my senior teacher. Thank you very much.
Thank you, sir.
Thank you, Professor Sattar. So now I would go to my dear friend, Dr. Azad. You want to unmute?
Thank you, Chandan. Thank you, Dr. Farjana, for your marvelous presentation. I think all of us have learned quite a bit from this presentation. And the landscape of anticoagulation has changed hugely over the last few years, even in Bangladesh. Nowadays, we mostly prescribe drug, rarely warfarin. And drug is actually suitable for most of the clinical scenarios, but it is not suitable for hemodynamically significant pulmonary embolism, not suitable for mechanical heart valves, not suitable for massive iliofemoral DVT, not suitable for pregnancy, and severe renal insufficiency. But in some cases, apixaban has also been used in when the creatinine clearance is 15 ml or lower than that. But other drugs, they're not indicated in severe renal insufficiency. So you have covered I think almost all the aspects of anticoagulation in your presentation. So I'd have very little to add. Yeah, I've learned that we can use warfarin at a dose of 5 mg or less in early pregnancy. This is a very good thing. But I'd like to add just one more point, and that is warfarin is safe during breastfeeding. It's very much safe. So I would like, instead of commenting further, I'd like to ask you a little bit, a few more questions, if you allow me. Is it okay?
Yes.
Okay. So how do you anticoagulation in patients with renal insufficiency?
I believe that's a brilliant question. And, both in Bangladesh, US, we treat so many patients who are having like renal insufficiency. And I agree with you. So most of the cases previously, we used to use only warfarin or maybe unfractionated heparin for our patients who are having renal failure. However, now the landscape has been changed, and only the Eliquis among all the DOAC is only recommended to use for patients who are having renal insufficiency, including the dialysis patient. And as you highlighted very nicely, that other DOAC, they are not used. So in my practice, almost, I should say 99% of the patients who are having dialysis, we use Eliquis, and that our nephrology colleague also support that, except as you highlighted, like patients are having mechanical heart valve, or patients are having maybe antiphospholipid syndrome, then it's like different scenario. So most of the cases, it's Eliquis.
Okay, one more thing. How do you manage a 70-year-old lady with non-valvular AF who recently had embolic large cerebral infarct? How will you manage the anticoagulation?
That's a wonderful question. And I believe, that could be challenging, because what I will do, I will sit together with the patient. What I do in real life, I will sit together with the patients, like family or like close, who is the making healthcare decision or helping the patient with healthcare decision. I will also try to find out, is there any other risk? For example, fall risk. Does the patient, this is the 70-year-old lady, any history of past medical history of GI bleeding or any other bleeding? So if those are not significant, then I will choose that, okay, which route they want to go, if they are comfortable that, okay, checking the INR, or if they feel that, okay, DOAC will be suitable. Because, the fact is, majority of our patients, because I practice in a underserved area, majority of our patients are still not able to afford DOAC. So I need to think about the broad scenario, that which will be indicated, which will be safe, and ultimately if they are able to afford the DOAC. So I will take consideration all those before finding out the safe anticoagulation for that patient. If you have any other context, I'm happy to provide that.
Okay, thank you.
Ajad,
yes,
Chandan, if you allow, can I enter into this point?
Okay. Please, sir, please.
Okay. because this is a nice question raised by Azad. This is very much common in our setup also. I am not sure Dr. Sujan Saidur is available or not, because he is working in UK in the stroke specialist. He is in large, what Azad told, in a large infarct, will you go for warfarin? In that condition, there may be intralesional bleed, and that can make another catastrophe. So what Farjana was talking about, that to talk the benefit and risk ratio of the patient, that might help, that might deteriorate the condition. That was my question. I'm not sure what is the practice in the UK. If Sujan is available, he can tell that how they used to do.
Sujan,
Hi,
you
sir.
want to make a comment? I know that you are there.
Hi, everyone. Fantastic presentation, Farzana. That's absolutely brilliant. And I think all the clinical scenarios that you've brought forward is really relevant to our practice. My line was very poor, so I didn't really get the question, sir. Was it about AF and anticoagulation in stroke? Is that what we're talking about?
No. It was a large infarct, whether we should use...
Sorry, I can't really hear.
Chandan, you can repeat for him.
So Azad, did you specifically ask, like, so patient has a large stroke.
Yeah.
Now, the reason for anticoagulation, is
Sure.
it atrial fibrillation or pulmonary embolism or DVT?
No, it is a non-valvular AFib with a large embolic stroke.
Right. So
Okay.
Again, this is the bane of life, and we come across it quite frequently. So the current guidance is, if someone presents with a stroke, and we tend to go by the severity of the stroke. So we use NIHSS score, and we can classify the stroke severity to mild, moderate, and severe. And if it's less than 5, so we call it mild, and if it's between 5 and 15, it's moderate. And if it's more than 15, it's severe. And we also look at the images. So if, say, for example, some patient with atrial fibrillation, they mostly have cortical infarcts, but sometimes the infarct volume may be very small, whereas some patient will have a larger volume infarct. So if it's a small volume infarct and the NIHSS is less than 5, then we tend to initiate the anticoagulation within 3 days. We don't actually have to wait for 14 days with aspirin and then initiate it, because we know the longer we wait, the greater is the chance of that person having another infarct from the AFib. If it's a moderate infarct, then we tend to wait for 7 days before we do that. If it's a large enough, then we obviously have to wait for 14 days and beyond. There's an interesting rule called the 1-3-7 14-day rule. One is someone presented with a TIA and they have AFib, you can start DOAC or anticoagulation from day 1. So day 0 will be the day of the event, and day 1 will be the next day. And as I said, if it's a mild stroke, then it's 3 days, then 7 days, and 14 days. I hope that answers your question.
Yes, thank you very much. Yes.
Sujan.
Yes, sir.
Please don't leave. Actually, I was asking this question to you through Azad, because this was the question of Azad. I interfered. Large infarct, what you do in your setup, that you wait, because large infarct, there is a chance that there may be bleeding within the infarct and the patient may deteriorate.
Absolutely, sir. So
what you do, that you want to know.
So that's what we do. I mean, so what I've sort of said. So if it's a large infarct, then we'll have to wait for 14 days. There's no other option. One other thing that we at times do is that sometimes if it's a large enough infarct, you see it on the CT. So you may not want to do an MRI scan. But if you do go for an MRI, the blood sequences on the MRI, like the gradient echo, can give you evidence of presence of hemorrhagic transformation already. So if you see that there is a significant amount of hemorrhagic transformation, which wasn't evident on the CT head, but has been picked up on the MRI, then you at times can wait a bit longer. But obviously it's a risk and benefit, because all of us, we know the longer we wait, the greater is the chance of that person having another infarct. But normally it's sort of, the practice may vary from site to site and from physicians to physicians. But our practice is in our region is that if there is no hemorrhagic transformation, even if it's a very large infarct, we would still give DOAC after 14 days. At times you do come across people who will bleed when you do that. I have a patient in my unit who unfortunately had that, but it's the chance that you have to take, sir.
Thank you.
So Dr. Farzana, can I ask a few more questions?
Yes, please.
Is it okay?
Yeah, please.
So a pregnant lady with a history of obstetric APS, she's on low molecular weight heparin. And while on low molecular weight heparin, she developed heparin-induced thrombocytopenia. So how do you manage her?
I believe for heparin-induced thrombocytopenia for pregnancy, we have to see what is the 40 score. So we have already confirmed the HIT, am I right? You mean?
Yeah, right.
So I have to take a look. I have or fondaparox during pregnancy. I have to take a look into that.
Okay, right. And how will you manage anticoagulation in a patient who is on bioprosthetic heart valve?
So it's a very good question. So for bioprosthetic heart valve, the current guideline I was reviewing, they are telling that we can only use aspirin. We do not have to use any DOAC or any warfarin unless patient has any other thromboembolic risk. Only bioprosthetic valve, nothing, only aspirin is enough.
Okay.
Well, Farzana, can I just add
bioprosthesis, valve, and atrial fibrillation. Then what to do? It's my question.
So I believe, okay, so if the bioprosthesis and atrial fibrillation, I will calculate the CHAD-VASc score. And, depending on that CHAD-VASc, either patient can go to DOAC or warfarin. So I will have a consideration according to the CHAD-VASc score.
Okay, thank you. I think you have
I think Dr. Rahman wanted to tell something.
No.
Hi, everyone. So again, just based on that question about the bioprosthetic valve, there is a common practice amongst the cardiothoracic surgeons is to give warfarin for the first 3 months. That's the time that allows the epithelialization or endothelialization of the bioprosthetic valve. And during that period, there is a risk of valve thrombosis. So a lot of the cardiothoracic surgeons will actually cover them with warfarin for that 3 months. And as far as I say, beyond that, if they don't really need any anticoagulation, and aspirin, if there's a compelling indication for aspirin, that can be given. And sir, in terms of your question about AFib with a non-mechanical valve, as you mentioned that valvular AF will be patients with mitral stenosis, moderate or severe, and with all other mechanical valves. So you can essentially treat a patient with AFib with a bioprosthetic valve as a non-valvular AF and just give DOAC if there's no other contraindication. Thank you.
So thank you very much, Dr. Farzana. I think we have learned quite a lot. Thank you very much.
No, thank you. No, thank you, everyone. And I just want to make one comment, like especially that discussion in the stroke and anticoagulation in an elderly patient, right? I think everybody, Dr. Saidur, Dr. Farzana, and Sar made some valuable comments. Then I think everybody is clear at this point that the risk of hemorrhagic conversion and the risk of bleeding, I think those are the two things that we try to balance, and the risk of having a recurrent stroke, right? That those are the three things comes into play. And especially the patients who are the age 70 and older, One thing regarding anticoagulation that we need to keep in mind, first of all, what the guidelines say, and the second of all, what is the risk of bleeding, right? Especially as that comes to that age. So regardless what the guidelines say, having a good discussion with the patient about the risk of bleeding is the key. Sometimes I tell the patient which poison you wanted to pick. I have 2 poisons. There is no good answer. So all the answers are at risk. Like, okay, if you take the anticoagulation and, God forbid, you fall or you cut, and there will be risk of bleeding and there will be risk of hemorrhaging conversion. On the other hand, if you don't take it based on your risk of recurrent stroke, sometimes you can use that ABCD scores and the others, that it might be, you may have another stroke and you may have more debility on your way. So bringing patient into the conversation and help them understand and make that decision is the key in this type of scenario. I mean, sometimes I think that is the key, that participation, regardless what the guidelines say, but always I think it's a good practice to discuss with the patient and help them understand and help them make the decision, not us. I think that's the way we practice sometimes, not practice here.
I agree with Dr. Mitro, because in practice, I believe in shared decision making, as he outlined very nicely that no guideline, you, me, no guideline, patient family does not know guideline. They do not care about guideline. They care about what the risks they're having, what kind of benefit. So I always say, so this is the indication, and these are the risks come with. And one thing to remember that in US, anticoagulation is one of the drugs that the physician get malpractice lawsuit. So it is very important, as Dr. Mitro mentioned, to engage the patient, their family member, that okay, these are the risk of a stroke, these are the risk of bleeding, which side you want to go. So I was reading an article about shared decision making, and it showed that almost 50% patients chose, when they were involved in shared decision making, they chose to have risk of a stroke. Other people, they chose the risk of bleeding. So it truly depends upon individual patient engagement and their preference.
And I think that shows that improved patient satisfaction as well, regardless of the outcome. Because when it comes to the anticoagulation, that is a high-risk medication. And, we don't have a crystal ball and we don't know what's going to happen. So bringing the patient into the conversation is the key. So regardless of the outcome, because there will be time that regardless of guideline, that outcome might not be the one that you wanted. So bringing them into conversation, having that shared decision making is a good practice. And as Dr. Farzana Haq mentioned, that anticoagulation is the highest medication, that high-risk medication in this country, let's put it that way.
And also the guidelines are changing. For example, when I first started my job as attending physician, we used to only give low molecular weight heparin to the cancer patients with PE or DVT. And now the guidelines have changed. They're telling that, okay, DOAC is also acceptable and it could be only 6 months. So being up to date with the evidence-based, with the guidelines is truly important, as our distinguished panelists mentioned in their talk.
So thank you. I think we had such a great discussion. I'm really fascinated by everybody's comment. And I think anticoagulation is still a mystery. And again, as I mentioned, that we really do, we try to go by the evidence, but still we don't have that crystal ball or magic wand, whichever way you want to put it. Excellent. And thank you, Dr. Saidur, joined as well, so that we know their perspective from UK as well. So again, thank you everyone joining today. And thank you to our speaker, thank you to our panelists, thank you to our participants, and thank you. Have a great night.
Thank you everyone. Truly appreciate your presence and your valuable insight.
Thank you, Farzana, once again.
Thank you very much.
Thank you.
Thank you, Chandan.
Thank you, Chandan.
Thank you so much, Dr. Mitro.
Thank you.
Thank you, everybody. Bye.
Bye.
Bye-bye.
Sir, Assalamualaikum, sir.